and is a director of MSc Genetic Counseling Program at El Faisal University. He will present today a great lecture on novel therapies for BQ. Please, Dr. Moeen, the floor is yours.
السلام عليكم ورحمة الله وبركاته. جمعة مباركة وصباح الخير واللهم صل على نبينا محمد. هم الرجالة راحوا فين يعني؟ أنا شايف كله mostly females يعني. في معلومة طبعا شكر جزيل لبروفيسورة سناء وبروفيسورة علا للدعوة الكريمة في بلدنا الثاني. الله يعطيكم ألف عافية. في معلومة قالت لي الدكتورة علا اليوم إنه clinical nutrition في مصر كلهم physicians, which is يعني صراحة يعني something amazing that I see this يعني. احنا عندنا في السعودية clinical nutrition is part of applied healthcare program يعني مش أطباء يعني أكثرهم. Some of the GI specialists or fellows برضو بيتخصصوا شوية في nutrition, but mostly it is non-physicians يعني. This is something great. So I was given the task to talk about phenylketonuria, and I'm going to talk mainly about the classical phenylketonuria. So phenylketonuria, as you all know, is an inherited and one of the most common metabolic diseases that requires treatment for life. By the way, I'm going to send these slides to Dr. Ola, so anyone can, ask her for, so you don't have to really rush in copying or in photographing. It's an autosomal recessive inborn error of metabolism, and it is basically characterized by elevated level of phenylalanine in the blood. The normal levels are between 60 to 120 micromoles, and hyperphenylalinemia is the term for a blood phenylalanine level of more than 120. It is caused, the classic phenylketonuria is caused by mutations in phenylalanine hydroxylase, but there is also the other cofactor, which is tetrahydrobiopterin, and defects in tetrahydrobiopterin gene also cause a biopterin-dependent phenylketonuria. So these are some of the incidents of this disorder in different places or prevalence. In Saudi Arabia, we have newborn screening since 2006. So we know the taqriban, the incidence of, or the prevalence of phenylketonuria is about 1 in 14,000 newborns. So phenylketonuria treatment landscape, which I'm going to focus on, before 2018, and in all cases, the primary goal of the phenylketonuria management is to lower the blood phenylalanine levels. مش كده? So that's the main goal. So medical nutrition therapy has started in the 1950s, and it's existing since the 1950s, and you are much more informed and knowledgeable about the medical nutrition therapy for phenylketonuria than me. And the basic aim is to restrict the dietary phenyl intake, and this is from birth. Then in approximately in 1998, we came to realize that some cases of classic phenylketonuria or moderate phenylketonuria responds to a biopterin or sapropterin, or what is known as Kuvan, which is the cofactor for phenylalanine hydroxylase. And this is something that can be started from 1 month of age. It became available as a therapy in 2008 in Europe. And however, given all these therapies, so the nutrition as well as the Kuvan, still there is a lot of unmet need in phenylketonuria. So considerable patients do not respond to Kuvan, even with good adherence to the medical nutrition. Maintaining blood phenylalanine levels for less than 360 micromoles is difficult without intense clinical support. So this is some of the evidence of the unmet clinical need. So even in patients who report dietary phenylalanine restriction, many experience elevated blood levels, underscoring the inadequacy of this approach. So 72% of a patient in a survey from clinics that see patients with phenylketonuria report having blood phe levels of more than 600 micromoles, and 18% of these patients also have more than 1,200. So if you have elevated blood phenylalanine levels as you grow into adolescent or adults, it still affects your life significantly. So adults with PKU show a 42% impairment in sustained attention. And in adolescents with PKU, there is as much as 4-point decline in their IQ for every 100 micromoles of per liter increase in the lifetime blood phenylalanine levels. Adult patients with PKU are 50% more likely to experience psychiatric disorders, and adolescents with PKU can show up to 40% less frustration tolerance than age-matched controls. So this is a study that was done on patients who were treated with PKU, who were treated with metabolic nutrition, and then there was a 4-week of supplementation of normal diet, and the other group continued to receive a phenylalanine restricted diet. So you have the placebo group and the ones that received the phenylalanine, and you can see within a short period of time there was a higher incidence of depression, of agitation, aggressiveness, and fatigability, and so on and so forth on patients who went back on the normal phenylalanine diet. So the dietary management of phenylketonuria can be challenging, and I'm sure you are all aware of this. As these patients grow into adolescents and adults, it becomes increasingly difficult to control their blood phenylalanine level, and this is one of the major unmet clinical need for this condition. So what happened as an additional but more specific therapy for phenylketonuria? So in 2018, Plenzik entered the treatment landscape as alternative pharmaceutical treatment of phenylketonuria. So Plenzik, or pegvaliase, is the first and the only enzyme substitution therapy, and basically this is an innovative therapy. This particular enzyme, which is pegvaliase, it is phenylalanine ammonia lyase, and it is present in several organisms. So a pegylated recombinant version of this enzyme was introduced, and this is what is being used. So basically what it does is, in the gut, it converts the phenylalanine to trans-cinnamic acid and ammonia. So basically it destroys, or it prevents, the absorption of phenylalanine from the gut, and that is the basis of the therapy. So these were the clinical trials that this particular enzyme went through, and I'm not going to go into the details of this, but if anyone wants to read about it, I will just give you the summary of these clinical trials up to the phase 3 that led to the approval of the medication. One important point that I think everybody was looking for when starting a new therapy: are we going to be able to increase the natural protein intake? So this is from the study on patients during the trial who were on Plenzik, and it was clearly shown that you could increase the dietary protein from the natural protein in these patients who were receiving pegvaliase. So this is a major advancement in the therapy, because you don't want to give an injection on a daily basis and then you still have to use the restricted metabolic nutrition. So this was very important. So the summary of this study was basically so this was called PRISM study, so phase 2 and phase 3. Basically the study showed that this Plenzik is effective in reducing the phenylalanine levels to almost normal values, and these patients can go on a much more liberal phenylalanine diet. So let me just give you some of the local experience with Plenzik very quickly, just show you some of the data on some of the patients. But just to let you know that this is not a straightforward treatment. There is an induction phase for Plenzik, then there is a titration phase, and then there is a maintenance phase. And this takes some time for the patients to get on the treatment. So this is one of the patients that we started on treatment. You can see the pre-treatment values. So you have phenylalanine levels from 1,328 to 941. And once the treatment was started and the patient went on the maintenance phase, you can see how the phenylalanine has come down. So you have values up to 14, 13, 33, 95, something that we could not have imagined happening with patients with phenylketonuria. And when there was an interruption in peak values, you could see the phenylalanine going back again relatively quickly. So this is one patient. Okay, so this, I think I still have some. So this is the second patient. Also, you can see with the treatment, the patients respond very well. And to the extent that you have phenylalanine levels of 6, so we encourage these patients to take more meat, to take more natural protein in order to increase their phenylalanine level. So in addition to the 3 therapies, so we have the metabolic nutrition, we have the Kuvan, and then we have the Plenzik. What are the other therapies that are under development? So there is the oral synthetic cypiapterin. So this is so cypiapterin is actually a naturally occurring precursor of BH4. Okay, so this is different than Kuvan. And if you look at the difference between cypiapterin and saptoprin, which is the Kuvan that is used, Kuvan goes into the plasma and it gets converted to BH4. And there is a kidney clearance, and then it goes into the cell. Whereas this molecule, which is cypiapterin, actually crosses the gut, and then it goes directly to the cell, and it is not metabolized in the plasma. So it reaches in large quantities to the cell, and then it gets converted to BH4, and then BH4 obviously, improves the activity of the enzyme as a chaperone. And this molecule has a direct effect also on the phenylalanine hydroxylase. So in patients who were actually treated with Kuvan, this molecule was tried in clinical trial, and it resulted in additional improvement of phenylalanine levels with different variants. Many of these variants, mutations that you see, cause classic phenylketonuria. So this molecule increased the activity in PKU variants, including BH4 non-responsive patients. So far, this is the trial. It is called Affinity, and it is a phase 3 clinical trial for this particular molecule. So in summary, the primary endpoint was met in the placebo-controlled portion of the study with a statistically significant reduction in blood Phe levels. 93% of the participants with blood Phe levels of more than 600, and 84% of participants with blood Phe levels of more than 360 at baseline reached their target level. So it's very exciting, a new medication in Horizon. A significant reduction in blood Phe levels from baseline was observed across a broad range of participants, including classical phenylketonuria, 69%, and those receiving Kuvan at study entry, 63%. And this molecule, which is cypiapterin, so it's different than sapropterin, which is the Kuvan, was well tolerated with no serious adverse event. So finally, or just semi-finally, another molecule that is under development is an SLC6A1A19 transporter inhibitor. And these two are in 2024. So what this molecule does, for those who know and treat diabetes, we have the transporter inhibitor for glucose reabsorption in the kidneys. Apparently, there is a transporter that transports and increases the excretion of phenylalanine and other amino acids in the kidneys. So inhibiting this transporter will result in excessive excretion of phenylalanine in the urine, and it will decrease the blood phenylalanine level. So this is now in clinical trials, and the molecule is called JNT 517, and it is designed as the first in-class orally bioavailable inhibitor of human SLC6A19. So the phase 1, phase 2 data showed that this molecule is well tolerated and results in rapid reduction of plasma phenylalanine without altering other plasma amino acids. and it is expected to come into use for other amino acid disorders like maple syrup urine disease and homocystinuria. So finally, there are a number of clinical trials and preclinical trials using gene therapy and messenger RNA therapy for phenylketonuria, and this is something coming in the future. So this is my last slide, just to show you that how the evolution of the history of PKU. Can we go back to that slide, please? Right. So PKU first identified in 1934, and then in 1950s you have the medical treatment. The Guthrie newborn card was in 1960s, and the first evidence that BH4 may help in the treatment of phenylketonuria, and the first approval in 2008, and then after that you can see the enzyme substrate therapy in 2018 with Plenzik, and now we are looking at sepiapterin and SLC inhibitor and messenger RNA and gene therapy. So very exciting time for PKU. Some of these therapies, of course, are going to be very expensive, but it definitely is going to bring much more options for our patients with PKU. So thank you so much for listening, and I think I'm almost on time.
Thank you, Professor Moeen, for the exciting knowledge for phenylketonuria. Actually, I have one question, if you kindly, please. For your patient started on Plenzik, do you perform some relaxation of dietary management for the patient?
Yes, so what we have observed in our patients, that once you start Plenzik and you get to the maintenance level, there is a significant reduction in phenylalanine level that requires actually to increase their protein intake. Some of them are even liberalized completely, and still their phenylalanine is at the lower end. So yes, so the answer is, but it has to be done gradually, and it has to be done with collaboration and with supervision from clinical nutrition, slowly increasing the protein intake until you reach the balance between the protein intake and the phenylalanine level. But some of the patients, Dr. Ula, actually you have to liberalize completely their diet in order to achieve normal phenylalanine level. So it is that effective in some patients.
May I have a question about SLC inhibitor? I know that they inhibit the uptake of large neutral amino acids ADOL. How I can move with this, and my target is only phenylalanine, not all the 9 large neutral amino acids.
So yeah, this is an excellent question. So this particular molecule is tweaked in a way that it affects more the reabsorption of phenylalanine. So it is more specific, but when this was used, it did not result in the reduction or severe reduction of other amino acids like leucine, isoleucine, and valine for maple syrup urine disease.
Do I will have to substitute the other amino acids?
No. Because you are going to liberalize the diet in these patients. So they were on protein-restricted diet, and when you use this transporter, you are going to increase the excretion of phenylalanine and possibly other amino acids as well. But on the other hand, you are replacing them, through increased protein intake.
شكرا دكتور.
And the oral ceftobiprine can be used within the range of age of 30. Age limits. What is the cause? How to benefit more to less age than this old ages?
So Kuvan, or the Kuvan, which is the approved BH4, The approval is from 1 month and on,
Yes.
1 month of age. But there are patients that we can start earlier, and it is very safe medication. For Plenzik, the approval in Europe is 16 and above, and in the US is 18 and above. But there are studies that are going on in younger population, and we have a patient who was 12 years old. We started him on Plenzik, and he's doing remarkably well. And this patient had, high levels of phenylalanine, so we elected to start this patient earlier, and that was published also on the use of Plenzik in younger population. Do we have Plenzik in هنا
No.
ولا؟ not yet.
Any other
يعطيكم العافية.
questions? Thank you, Dr. Moeen, for this very knowledgeable